Assalamu alaikum wa rahmatullahi wa barakatuh. In the language of peace and love, I greet you a very good evening. I'm Hawa Solomon. Welcome to another edition of Health Matters. Pancreatic cancer is up for discussion, and it is for the month of November. It's highlighted on the World Health Organization calendar, so please take note of that. Lots of information out there. We'll be talking to specialists about it. Please do interact with us during the show, our live WhatsApp line. We've already received questions. If you are added to our WhatsApp number, please note you can interact with us. Save the number and send your questions early on in the day on a Tuesday, inshallah. Remember to catch the repeats tomorrow of Health Matters as well as over the weekend on Sunday. There's also lots and lots and lots of Health Matters, informative, comprehensive health shows available on our YouTube channel. Please do click on the necessary links and also follow our Facebook page. We're very excited to announce to you as well our winner for our competition this evening. At least it's been taking place over the past 2 weeks, and very excited with Beitul Fit. We teamed up because everybody needs a little bit of a push during this holiday season. So a big congratulations to Ruqayya Pierby, and she's all the way from Benoni in Johannesburg. Thank you to everyone who entered. You are a winner, Ruqayya, from Benoni. You have won the Beitul Fit package, and let me tell you, loads and loads of great goodies available there. Please do visit Beitul Fit Boutique, Beitul Fit Zoom classes, and her various products that she has available on her website, Beitul Fit, BEITUL _FIT, Beitul Fit. Always a pleasure chatting to Beitul on air, giving us some great health, fitness and wellness advice. So don't forget, pancreatic cancer is the topic of discussion. We want your questions, comments and queries with our specialist. A little bit later on, he'll join us just after 9. But before that, let's get our COVID-19 stats video up. So there has been a warning to the Western Cape people. We love Cape Town so much, but you know, some people are not following the rules. Social distancing, wearing the mask is absolutely compulsory. There are some areas out in the southern suburbs. I've heard of Grassy Park and other places in Cape Town. Please, guys, you need to follow social distancing rules, wearing a mask. And if you do not need to go out, please do stay at home, especially those with underlying conditions. We appeal to you. There may be people walking around that are asymptomatic. That means they are showing absolutely no signs and symptoms of COVID-19, and they could be spreading it over to those individuals who maybe need to go out and have underlying conditions. So please keep yourself safe, and remember there are others that need to be kept safe as well. So we continue our wellness insert with Zaid Ishmael. Inspiring author, a mental health advocate, single dad, and a coach for life, Zaid Ishmael. We appreciate your time once again. Always a pleasure. Shukran for joining us. Assalamu alaikum to you.
Wa alaikum assalam wa rahmatullah. Jazakallah for having me again.
It's a pleasure. Always having your bright face on air with us, inspiring our viewers, alhamdulillah. Tonight's discussion is pancreatic cancer. We are highlighting World Pancreatic Cancer Day. What are your thoughts around the well-being of these patients that do have, any type of cancer?
I was just going to point exactly that out, is that cancer across the board has some very common underlying themes. And The one thing I can say for certain, and this is through experience with engaging with people that have been afflicted with cancer over the years, is that the one consistent theme is that there is a very, very deep grief that a lot of them carry with them. And it's not necessarily a grief related to the present moment in their life. It's usually about something from the past that they haven't reconciled yet or would want to have reconciled, but hasn't been possible. And the reason I raise this is because our body responds to this heaviness that we carry with us for such a long time, and eventually it manifests as illness. So pancreatic cancer, it's like all cancers, it's terrible. But understanding what is that underlying emotional stress that we introduce can significantly reduce the impact of the cancer and how difficult it is for us to deal with it.
Looking at
Because,
the,
as you know, sorry, just very quickly, one of the things that always comes through is that we need to always remember that stress is one of the biggest causes of illness, especially chronic illnesses. So just with that as the underlying thought, we need to just keep that to the back of our minds throughout tonight's discussion.
Yeah, and looking at, dealing with stress and depression, possibly depression, because that would, then be categorized as clinical depression. Does one then go through mild symptoms of depression when it comes to, having a chronic illness, and how does it actually affect the management of dealing with a chronic illness like that needs the necessary therapy, even surgery for that matter?
To focus on the depression side of it first, depression is unfortunately horribly misunderstood because we often position it as if it's something that happens to us, when it's not really something that's happening to us. It's something that we're experiencing in response to what is happening to us. And that's a very critical shift, because when we talk about depression, people start thinking brain scans, and they think of chemical balances, and they think of antidepressant medication and things like that. But it's a lot simpler than that, but a lot more profoundly impactful on our lives if we just stop and think about what causes it. Depression is a combination of two things, and I'm going to oversimplify it because we push for time. The two things that underlie depression is that we've had a sustained period of failed expectations, right? And that failed expectations is usually relative to one specific important area of our life. It doesn't have to be every area of our life, so we can't say that we don't have a sense of hope in everything. It's about something that is crucially important that then impacts everything else in our life as well, the quality of our life. And that brings me to the second point, which is the absence of hope. So the moment you have this frustration of believing that your expectations are never going to be met or fulfilled, and follow that on with the hopelessness that results from that, that sets you down the path of despondency and then depression. And when you experience that depression, because you've been doing it for such a long time, feeling that way for such a long time, it becomes a subconscious kind of normalized stress that eventually you forget is even there. And then you just believe that you're depressed, but you're not just depressed. It's because there's something that has been unresolved for a long time that you've lost sight of.
Looking at the hopelessness and understanding it, what would you describe the duration of that feeling should be, or could possibly be, that you could, then understand the symptoms and the signs of depression when, partnered with the chronic illness and dealing with it? Is it a week, 2 months, a month, when it comes to that feeling of hopelessness? And how does one manage it?
The important thing to recognize is that there is no time frame for it. It's like there is no time frame for grief. There is no time frame for recovering from loss or betrayal. It's all about what it is that we take from it and what it is that we need to have reconciled about it that holds us into that space for a long time. What makes it bearable and what makes it sustainable over a long period is that we find limited joy or limited optimism in other areas of our life. So say, for example, and I'm going to use this as an example because it's one of the most common causes of depression. If we have strained relations within our families or within with someone significant to us, right? That strained relation is not something that directly impacts every area of our life, but our quality of life in every other area is impacted by it because of the sense of significance that we get from it. So the more significant we feel, the more confident we are in the other domains of our life, and then we kind of get better overall, and we have a better quality of life. Now, if that strained relationship is so contaminated and so important to us that it starts affecting our sense of significance, our sense of self, what happens then is that we start withholding. And we start withholding ourselves in the different domains of our life. And by that way, what happens is that even though we still might experience moments of success and effectiveness in different areas like work and recreation or whatever else it might be, social as well, the fact that there's an underlying sense of insignificance, of weightiness, that will detract from it. So we'll maintain that for a long period of time until we either reconcile it in our minds about what we can take differently from it, or we can reconcile it with the person that it actually relates to.
So how do family, friends, and a possible support system help that individual to not fall into the hands of depression and there is this heavy burden of cancer on them as well?
The important thing to remember is that as much as the family and the support structure around the person is affected by it, they need to remember that it is most impacting the person who is afflicted by it, the person who has the cancer. And the person who has the cancer needs to, one of the most critical things for people who are suffering from cancer is that they often have, and I'm saying often because based on different people that I've engaged with over the years, they often lose sight of treating themselves kindly, thinking of themselves kindly, giving themselves a benefit of the doubt, recognizing their worth compared to others. And as a result, the cancer just kind of adds on to that sense of self that has already been contaminated, which suppresses them even further or subdues their spirit further. And that just adds to the stress, and the stress adds to the physical illness. So to break that cycle, the people around them need to do two things. The one is they need to make sure that they focus on the mental health of the person more than they focus on the illness, right? And secondly, and this is a critical one and very sensitive one as well, is that the people around the person suffering from cancer should do what they can to have an informed opinion of what treatment options are available. But the final choice must be supported as the choice of the patient, not the family. The patient must have primary focus in what it is that they believe is going to be the best thing for them, because the one thing that any healthcare practitioner will tell you is that if you don't believe in the treatment protocol, it will lose effectiveness, or it will be less effective than what it can be. So it's critically important for the support structure around the person who has cancer to support them in what it is that they want for themselves through that recovery process, or that response process, because that is what is going to keep their spirits in a healthy space, so that they can see that there is hope out of all of it, rather than continue to feel as if they are hopeless in claiming their voice once again when everyone else around them is pushing them for treatment option A or treatment option B, or whatever the case is.
Let's talk about a positive mind, body and soul, and especially when your body is, thrilled with pain, and inherently you feel down, you just physically feel down because of pain through the necessary cancer or the specific cancer that you're going through.
That pain adds to that sense of hopelessness, right? Because it just adds to everything else. But the one thing I can say with absolute certainty is that cancer is not a death sentence. And this is something that a lot of people, in fact, a lot of people that have had cancer asked me about this up front. Like, they've been given X number of weeks or months or years to live, and what now? And the first thing you need to recognize is that you've been given that duration based on your current state and your current circumstance and the current options available to you. The moment you choose something that breaks the cycle of where you're at, it changes that outcome completely, it changes the probabilities completely. And when you focus on the pain, you focus on the illness, and you focus on everything that's wrong, all you're doing is you're feeding the cycle that got you into that state in the first place. So what you need to do is you need to recognize what are the options, what can be reversed, what can be changed, What can you do differently? Focus on quality of life. Quality of life, quality of relationships is the most important thing at that point. And once you start improving that, everything else feels lighter, and then you start seeing opportunities for how it is that you can recover from this, rather than looking at what you need to get in place before this thing overwhelms you.
Shukran so much, Zaid Ishmael. That's where we have to leave it. Appreciate your time once again. Connect with zaidishmael.com and his various positive self-help online and group facilitating areas, and he's definitely someone that you need to connect with if you need that positive vibe within yourself. Always a pleasure, Zaid. All the best. Assalamu alaikum. We'll go for a quick ad break. When we come back, more on Pancreatic Cancer Day. Welcome back. Pancreatic cancer, World Pancreatic Cancer Day is what we are highlighting, and as much information as we can get out is available to you. And remember, Cancer, CANSA, is one of the biggest organizations here within South Africa and Africa, where you can find loads of information on cancer and pancreatic cancer. Let's now connect with our COVID-19 survivor, as we highlight every week someone that has gone through, so we can continuously be informed, understand, and also relate to each other that this is really out there happening and how we need to protect ourselves. Assalamu alaikum to you, Malika Mayers.
Wa alaikum salam. How are you?
Alhamdulillah, for someone that's very active, and we always find this a bit surprising when we speak to a few of our COVID-19 survivors, and I'd love to hear your story, seeing you're a mother, part of the athletic club, you're also in IT as well, so an array of different caps that you keep, so thank you for your time once again. Malika, if we could start with you with regards to your first experience with COVID-19 and its symptoms.
Okay, I had very mild symptoms. I was mostly asymptomatic.
Okay.
The only symptoms that I experienced was sort of very strong burning feeling in the back of my throat. I was in contact with a friend of mine who luckily was very responsible about it. She called me immediately when they found out that they needed to be tested. And with that, I was able to isolate. I've got a mother that lives with me. She turned 82 today.
Sure.
And I was able to protect her from being infected. I was literally the only one in my household that got infected because of her early warning. So I'm very appreciative of that. And that speaks to just how we need to take care of each other. My husband got tested. He was negative. And that was really the only experience that I had that led to me being tested. My symptoms were extremely mild. By week 2, I was only experiencing fatigue, really, and a drop in my oxygen levels, which caused me to just feel a bit tired, more tired than normal. Okay. And that was about it for me. That was the worst that it got.
I'm sure you had to make a mental decision and then physically understand that you had to completely isolate yourself from your family. As you said, needing to protect them, and this is the main aim of all of it when you are have contracted this virus. What was that isolation like, that separation like for you?
Well, firstly, what I needed to do was get my mother out of the house. Between me seeing my friend and getting the news that she was going to get tested, we needed to get my mother out of the house. So I called my brother. He collected her. So that was mother out of the house. I was completely isolated. Front section of the house. My family were generally at the back section of the house. And it was very funny. My daughter used to come and stand in the passage. The door would be open and she can see me. And she'd do little dances and have conversations with me from the passage. But I mean, that was the nearest that she could get to me. And I think for many of us, we forget. My daughter's 9 years old. Oh. She's a bit older, but I mean, we've got children that are much younger that don't understand that they can't be in contact with their families. So really for a period of about 2 weeks, you're alone and you've got to deal with yourself. I think COVID-19 really mentally is something that you need to prepare yourself for. My preparation was always not should I get it, it was if I get it. Okay. And I think really it's mind over matter when you get it to not panic and just save your energy, make sure that you can fight the thing.
How long were you in isolation and were you on any type of medications?
The medication that I was on is really the stuff that I took leading up to me being infected. So vitamin C, zinc tablets that I took slow mag medication. The only thing that I added was on the advice of a friend of mine was something called neurobion, B vitamins. And that was the regime that I was on before COVID-19 is the one that I carried on beyond. And because I didn't have any symptoms, I didn't need to take anything else. So the friend of mine that I was in contact with, she and I, sort of leading up to that, got into a bit of running, after lockdown lifted.
Yes.
And I said to her that, being fit and active is actually such an important thing as well, because I could feel that my lung capacity wasn't really impacted by it. I really had no breathing difficulties. What we're finding afterwards now, we started running again a little bit. We sort of just going around the block when the wind hits you, you do become sort of out of breath. So after effects of COVID-19 are still there.
Yeah.
It's not something that I experience every day, but from time to time, I do still start feeling tired. And then it's just, you've got to just tell yourself to take it easy, take the break, go and lay down if you need to. And just don't be so hard on yourself. Like you're surviving a pandemic. So just be easy on yourself.
Alhamdulillah. I love the idea that you said, if you get it, and if only more of us could think that way. And just to reiterate, not, when I get, maybe I'll get it, but just actually, when you're going to get it and how you would get through that. Tell us about what's happening in the news. There's been these crazy messages about how Cape Town is had a spike, and there's great concern in certain areas. How do you deal with those sort of concerns with you and your family? Are they actually real? And if so, how do you guys deal with it?
So at the moment, look, my mom's moved back home, so we're sort of very cautious still around where we're going and who we interact with. I think we can see it from the numbers. We are seeing a spike in infection rates again. And for us, it's still about being safe. Same regimes. I've now come out of my COVID battle, but my family are still, needing to know if they get infected, what will happen to them. So we can't sort of, be complacent about it. You do see out in the shops, out in the streets, people don't always wear their masks anymore. It's like level 1 for them now means that COVID-19 is gone, and it's actually not. Level 1 was for us to recover as a country. And I think we are really seeing the start of our second wave, especially Cape Town and Eastern Cape numbers are going up drastically as well.
Is it something that you worry about? I know some people are like just taking it easy with the news. They say, oh no, we don't see the COVID people, where are they? We see empty bed hospitals. They didn't see the spike, the craziness that actually happened behind the scenes with the doctors when we were speaking about it. Maybe not necessarily keeping up to date, but with you, are you someone that actually keeps up to date? Are you paranoid about it? How do you deal with the information and your family?
So I'm not paranoid about it, but I do, with the kind of work that I do, stats is something that excites me. And I'm the one that will keep track of, what are our numbers on, what is the infection rate every day. During my COVID-19, this is something that I did as well with my COVID-19, I'm going to call it the battle. I used to keep track of my own stats. So every single day, every 2 hours, take my blood pressure, take my pulse rate, what are my oxygen levels. And I actually have this little spreadsheet that maps out the graph. And that's the graph that I used to send to work, send it to the nurses. The company that I work for is quite good. The nurse phones you every single day to check up on you. So my target was always, before she phones me, I need to have sent her the file so she can see what's going on. And so yes, I do keep track of it. I'm not paranoid about it. It sort of has helped me in my planning. And when I say planning, it's sort of, again, coming back to when I get it, what is the plan and the steps that I need to take to make sure that we are safe, or the people around us are safe. So not too paranoid, but it's real, it's out there.
But it helps you cope. Malika, what are your what are your last words, and whether it be words of warning, wisdom, to those that when they eventually get it?
Let's just be prepared. Make no mistake, at some point, I think all of us will get it. It's extremely easy to pick it up. Within a few minutes, you don't know what is out there. You don't know who's infected. If you looked at me the first week or so, I didn't look like I had COVID-19. I could have very easily been walking around in the shops, touching things and, infecting people. So I think we must just be realistic about it. At some point, we will get it. Don't panic when you get it. Save your energy so that you can actually get over it.
Monica Mayers from Greenhaven in Cape Town. Thank you so much. Shukran, Jazakallah, for your time and sharing your story and advice. Please do keep safe, and the rest of Cape Town as well. And if you can, broadcast that advice to neighbours and friends that you do see not wearing a mask. Please be a benefit to society and remind them, because it's some scary stats happening in Cape Town. Shukran again, all the best. Until our next survivor, when we speak to again next week, same time, same place. There we have it. Every week we update you on our COVID-19 survivor, but still highlighting World Pancreatic Day here on Health Matters just after this.
Pancreatic cancer affects the pancreas, a digestive system organ located in the upper abdomen. Anatomically, the pancreas is divided into 3 regions: the head, body, and the tail. Cancer is an abnormal growth of cells. Most cancers of the pancreas are adenocarcinomas that arise in the ducts responsible for producing digestive enzymes to break down food. They tend to occur in the head of the pancreas and may grow quickly. About 10% of pancreatic cancers are endocrine or islet cell cancers. These tend to be more slower-growing tumors located in the body or tail of the pancreas. Other types of cancers, like lymphomas, sarcomas, acinar cancers, and solid and pseudopapillary cancers, may also arise in the pancreas. Pancreatic cancer is diagnosed using imaging and biopsy, following suspicion of the disease based on a set of symptoms. These symptoms can include jaundice, dark urine, light stool, weight loss, fatigue, upper abdominal or back pain, fullness after eating, and new or recent worsening of diabetes.
Welcome back again. We want your questions, comments and queries. We're broadcasting live on channel 347 DSTV. You can also catch us anywhere in the world across the beautiful oceans and the seas. That is on www.itvnetworks.tv, and that's click on live stream. We're also live on Facebook, and you can catch our shows and other shows on our YouTube channel. But for now, let's chat to our liver and pancreatic surgeon, Dr. John. A very good evening to you, sir, and welcome to ITV.
Hi, good evening, and thank you so much for having me here. It's really wonderful to see that you guys are promoting pancreatic cancer. It's really something that's hidden away and tucked away. We talk a lot about breast cancer, we talk a lot about World AIDS Day, but we don't really focus on pancreatic cancer. So I'd just like to thank you for taking this challenge on.
Only a pleasure. Could you just create some sort of idea and detail around the video that was just played now?
So that was a fantastic overview of just the anatomy of the pancreas. A lot of people don't really understand the pancreas, and the pancreas is really important in terms of producing chemicals that helps to digest the food, and we call that the exocrine function. And so symptoms related to pancreatic cancer are often related to exocrine issues, which we'll talk about a little bit later. And then, as we all know, the pancreas produces insulin, which is responsible for regulating diabetes. And with pancreatic cancer, what we know, and the reason why sugars may worsen or diabetes may worsen, is because of a paraneoplastic phenomenon. In other words, the tumor produces a substance that actually blocks insulin from binding to the cells, and that's why the sugar levels go up. Now, we know that the location of the tumor is really important. So if we have a tumor in the head of the pancreas, it tends to block the bile duct which runs through the head of the pancreas, and the first presenting symptom is normally jaundice. And with jaundice goes pale stools, as we've heard, dark urine, as well as pruritus or itching. So our patients are often itching to the point where they scratch themselves and they actually bleed. So it's quite important to identify these signs early. If you are getting this, really you need to present yourself to one of the medical specialists. But the hallmark often is significant weight loss. By the time we're experiencing back pain, it's often infiltrated the nerves and it's already advanced. In the earlier days, when we didn't have such wonderful imaging like CT scans, back pain was often a poor prognostic feature. So these are just some of the sort of things around that video. Here you can see the tumors in the head of the pancreas, and you can see the bile duct running very close by, but not yet infiltrated.
So a question immediately we're getting from our viewers are, as you mentioned, some of the symptoms, are there any additional when it does come to pancreatic cancer, and if it's possibly hereditary?
So that's a wonderful question, and there is a small set of patients where there is a hereditary cancer element, and often we start looking at familial types, and the familial types we talk about is normally the age is less than 55, and you've had two first-line relatives who develop pancreatic cancer. So it's slightly earlier than the usual 6th decade of life. So that's a familial subtype. But there are genetic mutations. And again, these are small amounts of patients with genetic mutations that may develop pancreatic cancer. One of the famous mutations that we all know about is called the BRCA mutation and the BRCA2 mutation. One of the famous actresses that we all may know is Angelina Jolie, who's carrying this. And we all talk about the breast cancer risk and the uterine cancer risk and the colon cancer risk, and we never really focus on the pancreatic cancer risk. So there are certain genetic aberrations that are involved. There are others which are rarer, like the MLH1 and the CDKN2, but I wouldn't really focus on those at the moment. But there is a sort of genetic and a hereditary component. So if you do have a relative, you should go and seek medical advice, and probably earlier screening is important.
Let's talk about the symptoms again, because that seems to be some of the questions that are coming out from our viewers. They're saying after the death of a pancreatic cancer patient, whoever discovered that piles was one of the symptoms experienced later on, and then they discovered that after his death. Is that true? And what truths are there in that information?
So that's quite an interesting question. There isn't really a link between hemorrhoids, or commonly known as piles. But the important thing actually is that patients develop something that we call steatorrhea. And what do we mean by this? As I mentioned earlier, is that the pancreas produces chemicals which help to digest the food and break down the food. And because these chemicals, and especially if it's in the head of the pancreas, can't get into the gut, so it can't actually digest the food, and we get maldigestion. And with this, depending on what type of diet you have, you get significant diarrhea, you get foul-smelling stools, and you often have oil that's floating in the water, and it's difficult to actually flush away. And often family members actually complain about this. It leads to social isolation of our patients because they have such bad diarrhea. And the problem is that the function of the diarrhea is is the real cause of why the piles comes about. So, and it's easily treatable because we do have pancreatic enzyme replacement therapy. And, this is really something that needs to be addressed urgently with a patient like that. Okay. And it needs to be treated in a setting of an expert who can help with this.
Let's look at some of the risk factors for a pancreatic cancer.
So again, the biggest risk factor for pancreatic cancer that we can change is really smoking. And whilst we focus a lot on lung cancer, we focus a lot on emphysema, we never really focus on its effect in pancreatic cancer. And in fact, cigarette smoking is solely one of the most important risk factors linked to pancreatic cancer. Now, there are other sort of risk factors like obesity, a sedentary lifestyle, physical inactivity, a diet high in fat, significant alcohol consumption, and again, whether this is a cause or a relation, is impaired glucose control. Now, there are other risk factors. So there's some genetic predispositions to set off things like chronic pancreatitis. Most chronic pancreatitis in our country is caused by cigarette smoking and alcohol, but there are one or two genetic abnormalities that cause chronic pancreatitis. And with this chronic inflammation, it predisposes you after years. to pancreatic cancer. And we've already mentioned one or two of the genetic mutations, which is the BRCA1, BRCA2, CDKN2A, and the MLH1. So I don't really want to get too much into the finer details of the genetics right now, but those are really the big risk factors. And the biggest thing that we can change is cigarette smoking, obesity, and physical inactivity.
I know maybe this is something that we should have established right at the beginning, but for those that are not aware, what is the real role of the pancreas in your body?
Right. So as I mentioned earlier, it's an interesting organ because it has two functions. One of the functions is an exocrine function, so it produces these chemicals that go down the main pancreatic duct and enters into the small intestine, the first part of the small intestine, and it helps to break down the food, and that's called digestion of the food. Later on, as we go down, we start getting absorption of that food. So if you don't have those chemicals to break down the food, we get maldigestion. The second role that it has is it secretes a whole lot of hormones into the blood. One of the most famous ones that we all know about is insulin, but there are a whole host of other hormones produced by the pancreas, including glucagon. There's some things called vasointestinal polypeptide. There's a whole host of hormones, which is really beyond the scope of this discussion. But the point is that it has an endocrine role and an exocrine role. We can live without a pancreas, and there are patients that have had total pancreatectomies, but lifestyle is really challenging and really difficult without a pancreas.
Let's talk about what percentage of patients actually present quite early, and why do they present late if that's the case?
So, excellent question. And unfortunately, because this organ is hidden deep down, it's literally over the spine, hanging over the spine, it's fairly deep. We often don't see symptoms, and most patients present with late disease. So only 20% of the patients that we see will present with what we term early disease or resectable or operable pancreatic cancer. 80% of those patients present with either metastatic or what we term locally advanced disease. In other words, I'm sure you saw that pancreas, and it hooks around two main blood vessels that supply the intestine. That's called the superior mesenteric vein and the superior mesenteric artery. As soon as those vessels have been involved by the cancer, it makes it almost impossible for us to cut out this tumor. So majority of patients, of those 20% that present with pancreatic cancer that is resectable, unfortunately, a lot of them are carrying multiple medical problems like significant heart disease, like significant lung disease, which makes them really unfit for a 6 to 8 hour operation. And doing what we term a pancreatic duodenectomy, which is removing the head of the pancreas, a bit of the duodenum, the gallbladder, part of the stomach, and then reconstructing all of that is really hard work for a person's body, and one of the most complex abdominal operations that we can get. And so we actually only take about 12% of these patients to surgery.
Okay, we talk about surgery and other complications after the short break with our pancreatic and liver surgeon, Dr. John Duval, just after this. Don't go anywhere. Assalamu alaikum. Welcome back as we wrap up World Pancreatic Day and highlight it with the color purple. Hope you're wearing yours too, to create awareness, understanding, and also more information. If this is a cancer that can possibly be hidden and not detected early, things can get quite worse. We speak to our specialist liver and pancreas surgeon, and quite an interesting word they called hepatopancreatic biliary surgeon. So both pancreatic and liver. So I took upon that challenge to say that, Doc. Welcome back, Dr. John. Some of the questions that we are getting in, and that's around, again, diabetes, and some of the symptoms. So I'm diabetic, I'm suffering from a burning sensation in my feet. I'm also type 2, 51-year-old. I'm not too sure if this is with related, but he's worried about the fact that he does smoke and the toilet is a problem. They do complain badly about the smell. So is it somehow related differently to his diabetes, or could it possibly be a pancreatic issue?
So the burning sensation in his feet is definitely related to the diabetes. Most of the time it's due to what we term a peripheral neuropathy, and it happens in a glove and stocking distribution, and it's normally in the hands and the feet. The gut is a bit of an issue, having a bit of constipation, and that really needs to be investigated by a gastroenterologist. I would really highly recommend that you go and see a gastroenterologist, because there are other malignancies besides pancreatic cancer which are far more common that need to be investigated, particularly if you are having constipation. And one of the things that we need to make sure that you're not harboring is a colon cancer. So besides pancreatic cancer, you really need to be screened. At the age of 52, if you haven't had a colonoscopy, I would highly recommend that. And at the same time, some imaging can be done to make sure that nothing is harboring in the pancreas. So that would be my advice.
And the screening would involve a colonoscopy?
So the screening for colon cancer would involve a colonoscopy. So we just make sure that there's no obstructing tumors in the colon. And then we go on to investigate the pancreas with either just starting with a basic ultrasound of the abdomen. We know that the ultrasound doesn't work very well in the pancreas, especially in the retroperitoneum, especially if you are carrying extra weight. So if we are concerned that there may be a pancreatic malignancy, we'll actually go as far as doing a CT scan to ensure that there's nothing lurking in that pancreas.
So what are the conclusive methods of inquiring that you have got pancreatic cancer?
I think you need to see a specialist in the field. I think that's the first and foremost thing. There are a whole host of questions that we will ask, and we will investigate steatorrhea, or the symptoms of having significant diarrhea, oily diarrhea, or having constipation. On the other hand, it needs to be investigated by an expert. And there are multiple reasons for this. So there's a huge differential involved in this. We also know that with diabetes on its own, there's an autonomic dysregulation of the gut. So you really should seek expert advice. There's a whole host of reasons and issues that could be playing a part in the last patient, but I think that it's important to see a physician, just a normal GP, to give you a good screening option. There are blood tests that we can do looking at tumor markers, but they're not there for diagnosis. They're more there for follow-up of our patients and surveillance of our patients. So I think if there's any concern after a GP has screened you, then you need to definitely seek the help and advice of a specialist.
Which specialist are they usually referred to? You mentioned the colon specialist. Is there one specifically, or yourself, when it comes to pancreas?
Yes, so I mean, I think that there are a host of us. We're a very small body in our country, and they're probably, I'm the Secretary General at the moment for the Hepatobiliary Association of Southern Africa, and we have 106 members on our books. So essentially, there are very few, small number of us, and that includes in Botswana and Zimbabwe, slightly higher up. But we need to actually ensure that a GP sees a patient, and once a GP sees a patient, can go to a medical gastroenterologist. There's a whole host of medical gastroenterologists that can see the patient. And yes, we're always open. Any one of us is always available. If they need any advice, they're welcome to look us up on our website for the Pancreatic Biliary Association of Southern Africa. It's quite clear. We have guidelines, and we definitely help people.
Great stuff.
The right specialist.
Thanks, Dr. John. Okay, let's look at some surgical procedures and outcome. Is that always, the way to go? What is the surgical outcomes when it does come to early detection? And what other treatments are available for those, both with early detection and possibly late detections as well?
So that's an excellent question. So early detection is very important. And we know that the best outcomes for our patients is actually to have a combination of surgery and chemotherapy. Now, the question is whether the chemotherapy should come before or after. If it's very early at this point in time, the evidence still stands that we should offer surgery up front, and then we should offer chemotherapy. When we look at surgery, I mean, we're talking about 6 to 8 hours. The biggest problem is the joint, the pancreas, the remnant pancreas that we leave behind. The morbidity around this anywhere in the world is around about 30%. So that's a significant morbidity. In other words, there may be a leak from the joint. There may be complications associated with that. However, when we look at the death rate from this operation, it should be less than 3%, and that's according to international standards. So we've done really well in terms of patient selection, in terms of working our patients up preoperatively, in terms of looking at their cardiac status, their lung status, and then looking at the imaging to make sure that we operate on these patients appropriately. And then once we operate on them, the post-operative care with ICU and developing a multidisciplinary team that's involved in these patients' care is what gets us good outcomes. So once that's happened, we then talk about adjuvant chemotherapy. And there's a really important landmark trial that came out, which showed that the addition of chemotherapy confers better overall survival. Now, when we start talking about chemotherapy, now I'm going to make a little bit of a shift and go to the later stages. Before, in the last 10 years, because 80% of our patients are going to present with late disease. In the last 10 years, we've made great strides in understanding this disease. Prior to this, from diagnosis to death was 6 months with stage 4 disease or disease that had spread. When we have looked at some of the newer chemotherapeutic agents, we've almost doubled the survival to almost a year now with certain of the chemotherapeutic agents. Albeit they have a worse side effect profile, the quality of life on these chemotherapeutic agents is far superior than the quality of life of the chemotherapeutic agents. And I think that's the important thing and the message that needs to get out is that we have options to help you. And then what we have moved to now is that we're starting to do precision medicine. So in places like the US, in places like Europe, and in some of the Japanese and Southeast Asian countries, we actually, once the tumor is out, looking at mutations within that patient's tumor. And so we can actually then look at exactly what chemotherapeutic options are important for that patient. And since some of the reports have come out, we're getting 54 months overall survival, and that's approaching 5 years. And we never had that previously in pancreatic cancer. So there are multiple options available to us at this stage.
Let's look at the outcomes of genetic mutation in our population with regards to pancreatic cancer and how we need to understand our genes and our family history.
So that's so important because when we look at the world map, I'm working really hard right now on a PhD looking at gallbladder cancer, but we have done work on pancreatic cancer. And one of my good friends and scientists, whose name is Emmanuel Nekwe, who works in the laboratory at the University of Witwatersrand, he's looked at this for his PhD and the genetic expression profiling. When we look at the map of Africa, there's absolutely zero information that's come out in terms of the genetics of this disease from Africa. What we found in a very small cohort is we actually don't differ that much from the rest of the world, but our genes are very small. We've had a few different proteins being expressed, and this is ongoing research that's actually happening in the laboratory at this stage. It's in a second phase or validation process that's going on, and there's a lot of good work happening at the university right now, looking at the genetic expression profiling and our population and how it might differ from the East and how it might differ from the West or Europe. So I think this is quite important work that's happening in our country, but there's a lot that needs to go. Unfortunately, this costs a lot of money, and where we are is, it's quite difficult. So over the past few years, we've started to make some international collaborations, and it actually seems to be paying off in terms of looking at the genetic expression profiling of these very, very aggressive malignancies.
So, Dr. John Devoe, we have to wrap up. Unfortunately, our time's up, but I'd like you to leave us with some information with regards to support groups, possible registry information, and where people can find correct information on the World Wide Web.
So, I think that this is really, as I said, data is lacking in Africa. And one of the hardest things for me as a pancreatic surgeon to swallow is the fact that our national registry has registered only 200 cases of liver malignancies, gallbladder malignancies, and pancreatic malignancies in the last year. And what we know is that from a study that we've done at Chris Hani Baragwanis over the last 5 years alone, just the pancreatic malignancies was close to 500 patients. So because it's a sort of histology-based registry, we don't include the patients that are really advanced. And we really need to make inroads in changing this. The second thing is that there are support groups out there, but they're not great. Not everybody has access to them, and we know the Pancreatic Network, the Pancreatic Cancer Network support group is there, and we're really grateful for them. However, we don't have enough work being done in our public sector, and that's up to us who are now starting to develop this, and organizations like the Hepatobiliary Association to make sure this happens.
Dr. John, unfortunately, that's where we have to leave it. Please reach out to Cancer and also the Pancreatic Cancer Association, as well as the organization mentioned earlier by Dr. John. We appreciate your time, and please do keep the great work going on with regards to the research on pancreatic cancer and the rest of your colleagues. All the best till we chat again. Very good evening to you, Dr. John Devoe, pancreatic and liver surgeon. Next show, we will deal with ulcers. So more information on our Tuesday evening show. Join us this time, same place, same time, from our team here live in Johannesburg, and myself. Wassalamu alaikum and goodbye for now.